So I called Professor Shigeo to the table. We're very happy to have our friend here. He is a professor of diabetology for University of Kyoto, and he created a food center at his university of an impressive capacity, but he is also the chair of the IDF task force for the Pacific. Dear Shigeo, the floor is yours.
Thank you very much for your kind introduction. It's a great honor for me again to be invited here and to introduce you diabetic food problems in Asia, especially Western Pacific region. I will show you our data more precisely than this morning. Since 2001, we have collaborated with many doctors and nurses in various countries in Western Pacific region, shown here, regarding the management of diabetic food care. I have visited various countries in Western Pacific region to exchange our experience. On this common background, I would like to show you our multinational collaborative study of diabetic food. We launched several years ago with Asian friends. We investigated the characteristics of diabetic food patients, sugar food, their lifestyle, and the medical costs of diabetic food in Western Pacific region. 8 hospitals in Vietnam, Thailand, Philippines, Indonesia, China, Mongolia, Cambodia, and Japan participated in this study. We collected the clinical data of 419 hospitalized patients presented with a new food ulcer in those 8 countries in 2008. Today, I want to show you some data from this study. For diabetic food patients in Vietnam, Philippines, Indonesia, and Mongolia, duration of diabetes after diagnosis was shorter than 10 years, and the average of age was younger than 60 years old, and surprisingly, males are not predominant in some countries. This slide shows the food ulcer recurrence rate and the amputation rate. In Thailand, China, and Japan, where the patient duration of diabetes are longer than 10 years, food ulcer recurrence rate were high, that is 27 to 55%, and the amputation rate were 18 to 25%. This slide shows the median day until presentation after the onset of the wound. The range of the median days was from 14 days in Mongolia and Japan to 28 days in Indonesia. Late referral and consultation is a major and common problem in the Western Pacific region. In order to solve this problem of late consultation, we examined the lifestyle and behavior of high-risk food patients by using the same questionnaires. We asked the patients about the behavior of the high-risk food patients. This slide showed we asked the patients, if you find a bruise or foot sore, how will you act? Surprisingly, more than half of the patients in Cambodia, Vietnam, Indonesia, and the Philippines answered they will treat by themselves. And more than 50% of the patients in Cambodia, Vietnam, Indonesia, Philippines, and China answered that they will not inform the doctors. We asked the reason for late consultation. They answered that they believe natural healing and they believe they can treat food ulcer by themselves. The lifestyles may affect the outcome of the food patient to some extent, including high amputation rate in Western Pacific region. Why do patients believe so? In many developing countries in Western Pacific region, anyone can buy any medicine, including antibiotics and insulin, without doctor's prescription. Furthermore, they can buy antibiotics at a very cheap price. Amoxicillin 500 tablets are sold at the cost of less than $1 in Vietnam. These lifestyle, such as self-treatment, by antibiotics may cause a complicated results in bacterial profile. This slide shows the bacterial profile isolated from food development in various countries. The bacterial profile varied widely between the countries, and surprisingly, Staphylococcus infection was not most predominant in some countries. Furthermore, in some developing countries, sometimes no bacterial culture and no gram stain smear was done, even in critical ill patients, but antibiotics were prescribed. This slide was kindly given my Cambodian friend, Dr. Pathogen. His hospital, Preah Stomach Hospital, is one of the largest national hospitals in Phnom Penh, Cambodia. Microbiology lab opened in his hospital 2 years ago. This slide shows the results of the bacterial profile in his hospital. Staphylococcus is predominant. This slide illustrates the sensitivity of antibiotics to Staphylococcus, which showed the resistance to penicillin. Before the setup of this microbiology lab, they tended to treat many food patients with penicillin G because of the cheap price. The government support provided the penicillin G to the national hospital. And so after this result, they have changed the antibiotics from penicillin G to vancomycin as an empirical therapy. To summarize the problems of diabetic foot infection in our region, we can point out 3 major problems, such as a non-prescribed antibiotics patients can buy on his own, and the pharmacist recommends antibiotics, not doing bacterial culture and gram stain smear, not knowing local bacterial profile and sensitivity to antibiotics. Last year, we discussed the direct medical costs of diabetic foot problems in hospitalized patients. Compared with the GDP per capita in each country, diabetic foot problems pose financial burden on the patient and their families. Furthermore, in some developing countries like Cambodia, cost of antibiotics are much more expensive than amputation. Probably it is not rare that patients prefer amputation in order to reduce the medical cost. And then, what is the future problem, future potential problems in the Western Pacific region? This year, we have collected the latest data of diabetic foot patients shown here. The number of the current smoker is declining in every country. However, the diabetic foot patients have more advanced complications, such as advanced retinopathy and chronic renal failure and end-stage renal failure. This slide shows the recent report of the number of the people with peripheral arterial disease published in the Lancet. In Western Pacific region, low and middle income countries have many patients with peripheral arterial disease. We will have to combat with the increase of ischemic problems soon. This slide shows the number of the doctors per capita, and the number of the doctor per capita varies widely across all OECD countries. Indonesia, India, China, Korea, and Japan show the lower number of doctors per capita than the average. Despite the smaller number of the doctors in our region, more and more Asian Pacific doctors have an interest in the diabetic problems and attend international symposium on the diabetic foot held in the Netherlands. We really appreciate for Professor Karel Bakker for his great contribution to Asian countries, Asian doctors, to enhance doctors' motivation toward diabetic foot care. And he kindly provided us to study the latest knowledge of diabetic foot. Instead of podiatrists we don't have in our region, nurses plays important role in diabetic foot management, especially preventive foot care and daily dressing of the wound. In summary, what is the regional target in diabetic foot problems? Through analysis of regional data, we should treat diabetic foot infection more effectively, control tobacco and increase of peripheral arterial disease, educate the people since the childhood, educate the management of elderly patients to maintain quality of life, and make up the footwear which the patient feel comfortable and want to wear. In order to reduce amputation and improve the patient's quality of life and ADL in our region, we launched the Diabetic Foot Care Project as one of the main projects in International Diabetes Federation Western Pacific region, closely collaborating with WHO and the South Pacific Committee. I hope this project can succeed to solve these regional problems. That's all. Thank you very much for your kind attention.